Welcome to Nurse Practitioner Week. The presenter for this session is Kelly Delaney, an adult nurse practitioner. Ms. Delaney is a primary care nurse practitioner in New York City and has been a practitioner for 8 years. She received her MSN in Adult and Women's Health and RN from Yale University. She also has a Master of Arts in Psychology from Southern Connecticut State University and a Bachelor of Science in Criminal Justice Investigative Services from the University of New Haven. She is due to complete her DNP here at Frontier Nursing University in December of 2017. Her clinical experience includes college health, private practice primary care, women's health and sexual health, as well as long-term care. Today, Kelly works full-time in college health while attending Frontier's DNP program full-time.
Hello, I'm Kelly Delaney, a postmaster's DNP student here at Frontier Nursing University. Thank you for attending my session to hear about my journey with the DNP. By the end of this presentation, you will have learned my personal journey to the DNP here at FNU, learned about SOGI and the health disparities seen in the LGBTQ community. I will review the implementation of my DNP project in college health, how we intend to sustain these changes, and the effects of the DNP on me personally and my practice. My journey to nursing was not linear. I majored in criminal justice, investigative services in undergrad. I was a full scholarship athlete and captain of the lacrosse team while maintaining a 3.98 GPA. I knew I wanted to be a sex crimes investigator. My senior year, during my internship, I realized that for various reasons, including my personality, that was not the best place for me. A fact most people in my life had been telling me for 4 years, including professors who encouraged me to consider the FBI instead. I began to consider criminal psychology as a career and got into psychological research as a research assistant at Yale University. First, working with adults on probation, discussing mental and physical health treatment needs, and then working in neuropsychology on the basis of reading ability and disability in children, seen here with the mock fMRI I built to train our participants in. While working, I earned my master's in psychology, and while looking into PhD and PsyD programs, I came across NP programs, and my world changed. I entered Yale University's Gepin graduate entry program in nursing and eventually earned my MSN in adult and women's health in 2009. I've worked within private practice, college health, and virtual primary care over the last 8 years and taught as a preceptor and adjunct clinical faculty in sim, didactic, and clinical faculty roles and learned so much from each experience. Then, after 16 years with my partner, our world changed, and suddenly I had to start thinking about another human being and how to make their life as amazing as it could be. I wanted to be able to open new doors for myself and perhaps transition into a full-time faculty role. So I began to look into doctoral programs. Having done research previously and knowing my love for clinical practice, I looked into DNP programs. When I was looking at the program, it was important that I be able to keep the job I love, that the program would not only not impact my duties there, but it would somehow benefit my current practice site, and that it was a quality program. A friend of mine had earned her FNP at FNU and had nothing but great things to say. I knew from her I would be able to do the majority of my schoolwork responsibilities after work and after my new little one went to bed. And it was the only program that encouraged your project to be at your job site and driven by your site's needs. It was huge. New York City has been the center of so many monumental moments for the LGBTQ community, most notably the Stonewall riot. It's a mecca for LGBTQ youth and a place I'm proud to live and work. At a large university in this great city, the president of our institution charged the community to improve institutional capacity to collect and utilize data to set benchmarks, evaluate our progress on equity, diversity, and inclusion, and help inform campus strategic goals for equity, diversity, and inclusion in the future as it relates to all university constituencies and initiatives. With the input of the leadership of the Student Health Center, we centered my project on the collection of sexual orientation and gender identity, otherwise known as SOGI. SOGI is complex. The vocabulary used to discuss it is not inherently easy. Healthcare's tendency is to ignore the patient voice and boil it down to body parts and assumptions based on behaviors. So what is it? Think of sexual orientation as having 3 components. Identity. Do you consider yourself gay, lesbian, bisexual, straight, queer, or something else? Desire and attraction. What genders are you attracted to physically and emotionally? And behavior. What is the genders of the people you have sex with? Most important things to remember about this is these are fluid and can change over time, especially in younger populations. Sexual orientation and gender identity are not intertwined, and these are self-identified categories and cannot be inferred or assumed. Gender identity is an individual's sense of authentic self, not to be confused with gender expression or how society categorizes outward appearances. An easy way to put it is don't judge a book by how you interpret the cover. Again, gender identity is self-identified and can be easily determined by the simple question, what is your current gender identity? And should be followed up with, what sex were you assigned at birth? People whose identities do not align with their sex assigned at birth may not identify as transgender, and it's important to clarify this. Often people are not out as transgender and instead identify simply as their authentic self in a binary gender. Others may not adhere to the binary categories traditional of society and may identify as non-binary or genderqueer. Your role is not to assign any of this, simply to inquire. Discussing the LGBTQ community can be intimidating, like learning a new language that is ever developing. If you don't know what to say, ask. Never assume. I've noticed that while working with the community, my everyday vocabulary has shifted to being gender neutral, and I tend to use they as a pronoun until otherwise corrected, which is a good habit to get into. Another wonderful clinical technique to use is mirroring. Use the words your patient does to describe themselves and their body parts. For example, chest instead of breasts in a transgender male. These pictures have a few good things to know and things to avoid. Please take the time to read them. And being able to start the conversation makes a huge difference, because we know that LGBT youth are 2 to 3 times more likely to attempt suicide than their cis straight peers. The prevalence of smoking is reportedly 27 to 71% higher among gay and bisexual men, an astounding 70 to 350% higher among lesbians and bisexual women than the general population. For all men, heart disease and cancer are the leading causes of death. However, compared to other men, gay, bisexual, and other men who have sex with men are additionally affected by higher rates of HIV and other STIs, drug use, and depression. Lesbians and bisexual women have a higher rate of obesity, smoking, and stress, all of which are risk factors for heart disease, the #1 killer in women. Lesbians are less likely than heterosexual women to have had a full-term pregnancy. Hormones released during pregnancy and breastfeeding are thought to protect women against breast, endometrial, and ovarian cancers. And yet, lesbians and bisexual women are less likely to get routine screenings such as Pap tests and mammograms. Transgender persons may be at increased risk for heart attack or stroke, not only from the hormone use, but from cigarette smoking, being overweight, high blood pressure, and diabetes. They are also underscreened for cancer of organs that don't align with their sexual identity. It's important to emphasize, if you have it, check it. Patients may fear telling providers of any symptoms they have for fear of being told to come off of hormones. Don't be that provider. So, with the support of the university and the health center administration, the aim of my DNP project was to provide right care to this at-risk population. Through the collection of SOGI, we aimed to increase health disparity conversations and decrease the likelihood that patients would allow their behaviors in college to become habits and health risks as adults. This project began with education and continued with education. The kickoff meeting reviewed the literature and best practices on discussing SOGI, much as we just did, and role-played having an actual conversation about it. And then came the changes to the EHR every 2 weeks to figure out the best way for our health center to collect this information. The format of SOGI collection was taken directly from the literature to include sexual orientation, gender identity, and sex assigned at birth. The way we collected and documented this evolved throughout the project. As a health home, it is our duty to provide comprehensive preventative health care to our patients. Knowing that lesbian, gay, bisexual, and transgender people experience unique health risks depending on how they identify meant we needed to educate our patients to hopefully begin to prevent these. We utilized handouts from GLMA, Health Professionals Advancing LGBT Equity, tailored to how patients identify to discuss these disparity risks. A patient survey, also taken from the literature, was used to evaluate the comfort level with and quality of SOGI conversations to be sure what worked well with age-diverse populations also worked well with our largely young adult population. The biggest variable with any change endeavor is buy-in. Having worked here for 6 years, I had an idea of the kind of resistance I would face and who it would likely come from, and thus set out to change minds and behaviors in small increments over time. By the end of the project, 100% of providers had participated in at least one educational session on SOGI, and buy-in, after an initial drop from baseline, rose to its highest point by the end of the project, although it did fall short of my goal. In a survey of providers before the project began, the highest comfort for SOGI collection was through a patient-completed pre-visit questionnaire, which is also how the published studies collected this information. So that's where we started. While patients completed these at high rates, they were not connected with all visit types and only available if the patient webbooked their appointment ahead of time. So the next step was for providers to ask, first in preventative visits and then all visits. All of these methods were entered into the EHR in a way that informatics can pull the information easily. The final PDSA was focused on entering the data into a section of the chart that is free texted and in the future will carry forward to future visits, so you don't have to ask SOGI every time. This data, however, is not in a reportable field and was much less utilized. Before the project began, baseline data was collected through random chart review, 25 at each data point, and there was a 0% documentation rate of SOGI in our charts. As the project progressed, this rate surpassed our initial goal of 50%, and in the last PDSA reached a mean rate of 73%, just shy of our adjusted goal based on a review of 100 random charts per PDSA cycle. Although our last data point was 76%, which was above goal. Likely due to the age group retreat, many of the health disparities seen in sexual and gender minorities were already being documented by our providers: tobacco, drug use, alcohol use, HPV vaccines, STI testing, HIV testing. There were little changes in documentation rates, in large part due to this. The other major factor was that the health disparity handouts from GLMA were based on population data and contained information about cancer screenings that did not apply to our age group at large. There was a huge barrier for increasing documentation rates. The patient survey scores were largely contingent on them being asked SOGI. Without being asked, the highest score would be a 12 out of 60. As our collection rates rose, so then did our patient scores. What was consistent throughout was patients feeling SOGI was important for their provider to know, regardless if they were asked or not. Take into account the aim of this project, a mean of the percentage of visits at goal for SOGI collection and the percentage of visits at goal for documentation of health disparities was calculated. As you can see, there was a large increase during this project. By the final PDSA, 76.5% of patients were receiving right care based on how they self-identified versus 26.75% in PDSA 1. There were a lot of changes to be made and potentially new conversations to be had. Despite that, there was little change in time to complete notes for providers. Patient load was lower during the summer, but for the last PDSA was back to full capacity with still no changes in timing. So to summarize, in order to reach acceptable documentation rates, a variety of tools to collect SOGI were utilized, both patient and provider initiated. I'd wondered if one would be best, as the literature focuses mostly on patient surveys, but it was a combination that was needed in our setting. Whether providers utilized published handouts or not, they had consistently high documentation rates of health disparities. I had anticipated that providing easy-to-use charting tools would increase this if put in easily accessible areas, but there was no appreciable change overall, possibly because not all of the information was truly applicable. As the literature points to more millennials identifying as gender and sexual minorities, I anticipated this project to be well received, and it was. 7% of patients in chart review identified as gender or sexual minorities in the beginning of the project, and by PDSA 4, 20% did. What I did not anticipate was the number whose identities would not match the handouts, most commonly queer, and how that would impact conversations and comfort. I also did not expect that due to changes in the template being system-wide, medical providers in our SHC overseas would start to ask these questions as well. The findings of my project were shared via a poster presentation at the SHC's first QI week on September 19th, to which all 150 staff members were encouraged to attend. There was a lot of interest and excitement from members of many different departments within the center. My hope is these findings will spread SOGI collection to all departments, that all staff will be trained in SOGI, and we will create a formalized method of collection of preferred names and patient pronouns for all patients. Although not a formal part of my study, I did collect this data, and we were at about a 5% documentation rate of pronouns. The EHR we use is specifically designed for college health. The changes that worked can easily be shared with other student health centers on the same platform. Most importantly, our students will leave our university having experienced right care in an accepting environment, which is the basis of the New York City Department of Health's current public health campaign, Bear It All, following the release of the LGBT Patient Bill of Rights for New York City, rolled out by the mayor this summer. The most rewarding moment of this project was when a provider who had told me at the rollout meeting, "You know I cannot do this," charted her first SOGI conversation that she initiated. I honestly cheered out loud as I reviewed that chart. I've always been outspoken and passionate when it comes to LGBTQ care. I was the first provider in primary care at my site to prescribe hormones for transgender patients and expanded those services to include 3 NPs in primary care and 1 in women's health. That was an easy leadership role for me. This project, despite its positive results, was a challenge at every step, but I was able to access my project team and other admin members at my site that I had already had relationships with and get advice, and came out much more confident in a leadership role. What I learned most of all is that a leader is nothing without the support of the team they are a part of. And that personal motivation and passion is what gets you through the tough conversations, late nights, failures, and success. My experiences interacting with so many amazing people in a variety of departments and roles has allowed me to grow as a person and a professional. I came into this program as a means to a full-time faculty role, a passion I still have, but I leave this program with an understanding that I am capable of much more than I ever even knew to consider. When I graduate in December, I now see a world full of opportunities in leadership, administration, quality improvement, and faculty. I retain my passion for clinical practice, and the DNP from FNU has given me the tools to make changes not only to my patient lives, but potentially all patient lives. Thank you for taking the time to share my journey.